Everyone, welcome to another Monty Hard lecture. Today, as we're approaching the end of this year of lectures, we have a giant in the field. We have Dr. Sripal Bangalore, who will be speaking about contemporary management of acute pulmonary embolism. I think everyone here knows Dr. Bangalore. He is very well published. He's an interventional cardiologist and a professor of medicine with tenure at NYU School of Medicine, where he's also the director of the invasive and interventional cardiology, director of complex coronary interventions, and interventional director of adult ECMO, MCS, and PERT programs at Bellevue Hospital. He's also the director of the cardiovascular outcomes group at NYU Langone Medical Center. His clinical expertise is in complex coronary interventions, including CTOs, ultra-low volume zero contrast PCI, intravascular imaging, mechanical circulatory support, ECMO, and PERT. He has done extensive research with over 650 publications in leading journals such as New England Journal of Medicine, JAMA, Lancet Circulation, JACC, and many others. He has received grants from the NIH, the Agency of Healthcare Research and Quality, AHA, and many from the industry as well. And he was the co-chair of the Ischemic Heart Disease Council of the Society of Cardiovascular Angiography Interventions. He has been in the writing committee for a number of guidelines and position statements, including the American Diabetes Association position statement on hypertension, kidney disease, improving global outcomes, the KDIGO Controversies Conference, scientific statement on coronary heart disease screening in kidney and liver transplantation candidates from the AHA, and many others. So it's a real honor to have you here. Congratulations in an amazing career and, being so young. So we're really lucky to have you here with us today.
Thank you very much, and thanks for having me here. Um, I know you guys are already doing a fantastic job in terms of PE, so I'm pleased to kind of give my thoughts on this to this group. So these are some of my disclosures as it relates to this particular talk. I'm the national co-PI of PE new device that we just finished enrolling in that trial. I'm also on the steering committee of Perceive trial. We'll talk about this trial briefly at the end of this. So I thought I'll start with the case. So this is a 64-year-old male, hypertension ex-smoker, and he presented with heartburn and indigestion after a round of golf. Just like it's pretty common, so this particular patient attributed it to the food he ate, the hamburger and onion, which he had for lunch. So he didn't make much of it, and he decided to go to bed, but he woke up in the middle of the night, 2:30 a.m., now with chest pain. And several hours later, he's diagnosed with an acute anterolateral MI on his EKG. So he's taken to the nearest hospital, and this is his management. He's put on an oxygen tent. He's given analgesics. He's given antispasmodics. He's given anticoagulant, heparin. And this is the room he stayed in. And a lot of prayers outside his door, hoping that he survives. So if you're wondering who this particular patient is, this is President Eisenhower. The year is 1950. And for all the fellows there, it's important to recognize that at that point of time, 1950, the mortality rate for an acute myocardial infarction was 30 to 40%. In this day and age, I mean, we hear a lot of press about White House, and many times you can't believe what they're saying. I mean, so it's nothing new. So back in the 50s, the White House press release just think about the mortality rate of 30 to 40%. The first press release said President had suffered a mild coronary thrombosis. A few hours later, the word mild disappeared from the official description, and the President heart attack has been termed moderate. So this was around Friday, and this was what the newspapers covered over the weekend. Ike suffers heart attack, the recovery prospects are good. And again, I mean, think about a mortality rate of 30 to 40% and telling your patients, your prospects are good. Despite what the White House and the media tried, they were trying to allay, panic. On Monday of that week, the stock market opens to the biggest stock market crash since World War II. Because of this is called a billion-dollar heart attack. And so if you look at what happened, so he was admitted September 24, 1955. He was discharged November 11, 1955. Length of stay of 47 days. Think about the length of stay again. This is back in the day. This is President Eisenhower with his team of physicians at the VA. And just to complete his story, from his first infarction in 1955 until his death in 1969, Eisenhower had at least 7 myocardial infarctions and 14 cardiac arrests. And it's important to look at the progress of cardiovascular medicine. So if you look at 1950, the mortality rate is 45%. There wasn't even a concept of coronary care unit. And so after that, there was introduction of coronary care unit, defibrillation, beta blocker, coronary angioplasty, implantable defibrillator, primary PCI, introduction of DS, and so forth. So you can clearly see with time there is significant progress and significant better prognosis for patients with acute myocardial infarction. So these are the mortality trends for myocardial infarction starting from 1995 to 2015. So still not contemporary, but clearly if you look at 30-day mortality for STEMI, significantly reduced mortality compared to what was back in the day. To the extent, I mean, we'll come back to this, the 30-day mortality with the STEMI here is around 2.5, 3%. The same applies to NSTEMIs. We have made significant progress to the extent that the 30-day mortality is under 5% or typically around 2.5, 3%. So with that in background, let's talk about PE. So in terms of the broad categorization of PE, we have the AHA classification and ESC. Most of us tend to use the ESC criteria for risk stratification in PE. So ESC categorizes patients as low risk PE, intermediate risk PE, and high risk PE. Low risk PE are patients who have PE but no RV dysfunction and no abnormal biomarkers. If you have one of the two, RV dysfunction or abnormal biomarkers, you go into the intermediate category. If you have both of them, it's intermediate high risk category. And if you're unstable hemodynamically, you fall into the high risk category. The width of this pyramid would indicate the number of patients. So there are a lot more low risk patients, low risk PE, than patients who have high risk PE. Since we started an MI example and since we are all cardiologists, let's talk in terms of ACS equivalents. In terms of mortality, to begin with, the low risk PE has a mortality of 1%, intermediate risk PE has a mortality rate of 3 to 15%, and high risk PE has a mortality of 30%. And in terms of ACS equivalents, low risk PE is somewhat similar to low risk unstable angina. Intermediate risk PE is similar to STEMI and NSTEMI. But let's pause here. I mean, I just said if you have an uncomplicated STEMI and NSTEMI, the 30-day mortality is 3% or less. But look at this. The intermediate risk PE is mortality far exceeds that of STEMI and STEMI. And we'll come back to this particular paradigm and ask ourselves the question, are we doing are we treating them appropriately, and is this mortality acceptable? And high risk PE mortality is 30%, and this is very similar to acute MI cardiogenic shock patients. And PE is the third leading cardiovascular cause of death, right after MI and stroke. And there are a number of things that one should be aware of. It's the second most common cause of unexpected death in most age group. The biggest problem with PE is the diagnosis is missed in 70% of cases. And I can tell you, I mean, this is very, very true. I'm sure Dr. Kalik and others there have been spreading awareness about PE. And I'm sure if you compare rates of PE diagnosis prior to starting a program and after starting, you can see the diagnosis itself will significantly improve. And it is fatal within 1 hour after onset of symptoms in 10% of the cases. And if it is left untreated, the mortality is close to 30%. Sudden death is the first symptoms in around a quarter of these patients. So pretty morbid and morbid condition which needs urgent recognition treatment. The other problem we have with management of patients with PE is there is no uniform consensus on management of these patients. So if you look at the guidelines would say if you have a low risk PE, just anticoagulate them. Intermediate risk PE, the guidelines would still say anticoagulate them. And the reason to consider something more than anticoagulation for intermediate risk PE is only if the patients become unstable. So the guidelines would say if the patient becomes unstable, then consider advanced therapies. For patients who are high risk PE, the guidelines would recommend you lyse them or consider other advanced therapies. Okay, so as we talk about PE, I have two major rules. Rule number one is historically PE was considered a pulmonary problem, but our pulmonary guys will tell you we can always oxygenate them. It's rarely ever an oxygenation problem. Patient with PE rarely die from hypoxia. And I think this is the reason cardiologists need to be involved. The question is, what do they die from? So the reason patients with PE die is because of this spiral. So this is a RV shock spiral with obstructive shock and death. And maybe let's take a minute or so to review the pathophysiology of what happens in a patient with a PE. So if you have clots in the lungs, there is increased RV afterload, which causes RV dilatation, increased RV wall stress, and increased RV oxygen demand, leading to RV ischemia, RV decreased contractility, decreased RV output, and the decrease in RV output translates to decrease in cardiac output and decrease in systemic blood pressure. The reason I actually wanted to go through all of these is it took me a while to tell you guys that, in the pathophysiological sequence, there is low blood pressure, right? So it's late in this process, you see low blood pressure. So hopefully I can convince you guys that you don't have to wait for the blood pressure to be low to act on it, because if you do, you're already in this advanced phase of obstructive shock spiral. Um, so, if you look at the mechanism, pathophysiology here, can we somehow identify patients somewhere here who are at risk for shock and try to avoid and break this cycle of obstructive shock and death? So the second rule I have is we call the PE acute pulmonary emboli. I mean, even though the PE may be acute, so in other words, the lungs do not have clots, and the patient has a clot now. So from that sense, it's acute. But the issue is the thrombus is rarely ever acute. So what do I mean by that? So there are some data. Of course, most of the times PE starts as a DVT in the legs a couple of days to a couple of weeks ago. And there have been a number of studies. I mean, this is from our group looking at histological evaluation of acute DVT, looking for aging of thrombus. And what they showed in this particular study is the majority of clot in an acute DVT is an advanced stage of organization. So there is fibrosis, organization, endothelial growth, capillaries, fibroblast infiltration, etc. And the same has also been shown in an histological evaluation of clot from an acute PE, that there is this clot is in a late stage of thrombus organization. And why is this particular concept very important? We'll come back to this. Aging of thrombus would make it would have implication on the therapies we use. If the clot is not fresh, then the question is, can therapies such as anticoagulation, systemic fibrinolysis therapy really be helpful in such patients? To give you an example, this is a patient that I treated last year. Went on a trip overseas, came back, and echo. I think this was done incidentally, and they saw on the transthoracic, they saw something here in the right atrium. You can see that better here, something in the right atrium. He then went on to have a TE to better delete this. see if I can play this. And you guys can see here that there is something there. And the concern here was, could it be a clot? But it wasn't very clear whether this is actually a thrombus. So this patient went on to have a number of other tests. CTP was negative. They did a Doppler of his both legs, which was negative. They even sent him for cardiac MRI because the concern was, is this a mass? And the cardiac MRI was inconclusive. And they also decided to do a trial of anticoagulation. So he was on DOAC for 4 months. And interestingly, after 4 months, they did a repeat echocardiogram, and there was no change in size after 4 months of anticoagulation. So they sent this patient to me, I mean, more so to say, look, we don't know what it is. And the patient is very concerned that we don't have an answer for him. Will it be able to extract this and send for pathology? So we said, look, I mean, at this point in time, the only indication was to just do more for diagnosis purposes and not really therapeutic, because he did not have a PE. And we didn't think that if this little thing embolized, he would be at risk for any cardiovascular collapse. Anyway, we went in, did a mechanical thrombectomy, and pulled out this particular looking mass. So we sent this for pathology, and the pathology came back after a week, and this was organized thrombus. The reason I want to use this example is clearly you saw this. This was a patient who had this, and he was on anticoagulation for 4 months, and that anticoagulation did nothing to that size of the thrombus. So in other words, it's organized. So with organized thrombus, our therapies, including anticoagulation, are less effective. Along those lines, let's start with a particular this patient. So this is a patient from I think earlier last year, 45-year-old female, history of asthma. She woke from sleep, short of breath, cough, and immediately she thought this was one of her asthma exacerbation. Took some nebs. But the boyfriend saw that she was not doing well, and she immediately called EMS. And when the EMS got there, she was in a PRS, so they ended up intubating her, CPR for 2 rounds. They shipped her to a nearby ICU. In the ICU, she was treated with steroids and nebs for status asthmaticus and antibiotics for pneumonia. And day 2, she was extubated to high-flow nasal cannula. Around this time frame, she had a CTP, which was negative for PE. And so she stayed in the hospital for a steroid taper. And on day 11, she was noted to be acutely tachycardic. Her heart rate was 140, 150s. Blood pressure, typically being 130, 140s, is now slightly lower, 90s to 60s. And if you review her chart, she did not miss any doses of DVT prophylaxis. She was initially on Lovenox and then on subcutaneous unfractionated heparin. And vital status, 5 minutes later, she was tachycardic to 150s. Blood pressure being transiently low now has gone back to 130s. She is breathing around 30 respiratory rate and sitting around 93% on room air. Some of her labs came back. Troponin is elevated, BNP is elevated, D-dimer is elevated, lactate is negative. And because of suspicion for PE, she was sent for PE. This is around 8 p.m. And so this is the CTP. So I'm circling thing there, so you can see a saddle PE. More in right pulmonary artery. And this particular CT was read by an overnight oncologist. I'm circling something in the right atrium that was missed. But anyway, the did a second branches of right and left lung, early right heart strain. And I'll show you some more stills of this. And it's very important for people involved in the PE space to review your own CT scans, because clearly there is this big thrombus sitting in the right atrium, which is missed by even the overnight radiology read. So there is a clot in transit, in addition to a lot of clot in the pulmonary arteries. There is decreased RV-LV ratio. And to summarize her, so she's at a different hospital. She has a PE with large clot burden, including saddle PE. She has an increased RV-LV ratio. Her heart rate is tachycardic 140s, but BP has now rebounded back and it's now stable. She has positive biomarkers. She has negative lactate. minimal oxygen requirement. So this is one of our referral hospitals. They called us and said, "Oh, by the way, she's hemodynamically stable, does not need a lot of oxygen. What do you want us to do?" So the question is, should we continue anticoagulation or should we further stratify? So if you look at the guidelines for a patient like this, what does the guideline say? The guidelines would say for a patient with intermediate risk PE, you should further stratify these patients, preferably by using the PESI or the SPESI score. So this is what the ESC guidelines is saying. So since the guidelines is saying that, let's put that in practice. So this is the SPECI score. For people not in the field, the SPECI score has these 6 parameters. So you can see all of the parameters. So let's plug in our details for this particular patient. So she's tachycardic. She doesn't meet any other criteria. Just the fact that she's tachycardic gives her 1 point, and the 1 point is good enough to make her high risk. So the SPECI is saying she is high risk. The problem I have with the SPSE score is that it's not PE specific. For example, let's take an example of an 82-year-old female who has UTI, and incidentally, somebody does a CT scan and does a subsegmental PE. If you use the same SPSE score and plug it in, you see that because she's age over 80 years, she gets 1 point. And even this patient is categorized as a high-risk patient by the SPSE score. So it's not PE specific, and clearly for this particular patient with UTI, treating a subsegmental small PE is not going to make a difference in terms of her prognosis. And so this score doesn't guide the management. But anyway, since the guidelines say this, let's plug in more numbers. So here for this particular patient, she is hemodynamically stable, no oxygen requirement, and the PESI score would say a 30-day mortality is fairly high. I mean, we talked about STEMI and NDEMI. By those standards, mortality is 3 to 7% at 30-day, and the SPC is high risk. But these scores does not really tell us what the site is asking us. The site wants to know, can we just keep her here? We started on heparin. Can we keep her here, or do you want the patient to be transferred? So here we say the per team got on, and I'll come back to our exact thought process at this point of time. But we said we want this patient emergently transferred to us. So we said try to get this patient within the next hour to our hospital. So within the next hour, now it's around 9 p.m. The patient gets to our hospital. So she's transferred directly to the ICU. In the ICU, we have a left radial A line, and you can see the tracing on the A line. It may not project well, but here is 100 millimeters of mercury blood pressure, and you can clearly see now she's hypotensive. Hypotensive to the 80s and 70s with a narrow pulse pressure. So she has new hypotension. At this point of time, we said started on dobutamine and levofed for low blood pressure. At the same time, we have a cardiology fellow doing an echo and an ICU fellow doing a DVT scan. And the DVT scan shows that the patient has a left common femoral DVT. And the cardiology fellow is an echo, and you can clearly see this clot in transit. One of the big concerns if you have new hypertension is, did this clot embolize? But clearly it did not embolize, it's still there. And you can see that the RV is dilated, hyperdilated with a Connell line. So this patient was hemodynamically stable in the other hospital, as now new hemodynamic deterioration, and she also has increased oxygen requirement. Now the question is, could we have predicted this? In fact, we predicted this, the per team at our hospital, and that's the main reason we said send this patient to us ASAP. So how do we do that? So let's talk about normotensive shock in acute MI patients. So we all know in patients with acute MI, they can present with overt cardiogenic shock, but there are also a subset of patients who are in normotensive shock. By definition, normotensive shock is the patient has a low cardiac output, but the blood pressure is preserved. So the systolic pressure is 90 or greater without any pressors. And these are patients where they're compensating, they have a high peripheral vascular resistance, clamping down to maintain their systolic pressures. And what was shown by Judith Hockman and Venu Menon and others are, these are the patients, I mean, even though the blood pressure is stable, they're at high risk of hemodynamic deterioration. They need more pressors. Their in-hospital mortality is very high, 43%. And so back in 2000, there was a recommendation for aggressive management of patients with normotensive shock. So we looked at some of the data in the PE world. So this is our publication from the FLASH registry, which included patients with intermediate risk PE. Intermediate risk PE, by definition, have normal blood pressure or non-hypotensive blood pressures. So we define normotensive shock as patients with the blood pressure equal to or greater than 90, no pressures, but of a low cardiac index. And what we found in this registry was 1 in 3 patients with a preserved blood pressure are in normotensive shock. And we derived a score called the Composite PE Shock Score, CPES score, to predict which are the patients who can be in normotensive shock. The parameters that go into the CPES score is the first one is marker of clot burden. So does the patient have central clot? It can be either saddle or central PE. So if you have this, you get 1 point. The section to ask is this clot causing a strain on your RV? And the strain on your RV is measured by 3 parameters: elevated troponin, elevated BNP, or moderately or severely reduced RV function. 1 point to each of this. And third to ask is there anything else that can worsen the situation? So in other words, is there additional potential for additional clot embolization? And the parameter here is concomitant DVT. And because of this fact that this is part of the score, in our practice, every patient with a PE, with an intermediate or a high risk PE, gets a concomitant DVT. So we don't scan. I mean, we don't wait till the next day for the tech to come in and do it. We do a bedside DVT scan. And finally, the other parameter is the patient trying to compensate cardiovascularly? And this is measured by tachycardia greater than or equal to 100 beats per minute. So 1 point for each, a maximum of 6 points. And what we showed was the higher the number of points, greater is your incidence of normotensive shock. To the extent that if you have all 6, the percentage of patients with shock is close to around 58%. In another validation series, we showed that this could be close to 100%. And I can tell you for the last many years, this is the one we use for our PERT program. So all of our members, the pulmonary guys, etc., we use this CPES score for risk stratification of these patients, and make a clinical decision based on this. So the advantage of CPES when compared to SPECI, we talked about SPECI, about an 82-year-old female with UTI who had small subsegmental PE, which was rated as high risk by SPECI score. If you use the CPES score on the same patients, the CPES score is 0. So because it has all PE specific variables and potentially can also determine prognosis. So this is another paper of ours where we looked at 207 patients who were treated with anticoagulation alone, and we showed the higher the CPES score, the greater is the incidence of in-hospital adverse events, greater is the incidence of in-hospital mortality, hemodynamic deterioration, also greater incidence of cardiac arrest. And so going back to this particular patient, we had calculated a CPES score when the other hospital called us. And the CPES score is 6 in this patient. So the highest CPES score, it would say that our normotensive shock prevalence is 58 to 100%. Our risk of death is 40%, cardiac arrest is 40%, hemodynamic deterioration is 40%. So very high risk of in-hospital adverse cardiovascular events. And this was the reason we said ship to us ASAP. And clearly when she came to us, she deteriorated as the score had predicted. She became unstable hemodynamically. She also had increased oxygen requirement. And so now we have this patient in the ICU. So she is unstable and needing more oxygen. So what should we do now? Because this is a high-risk patient. This is no longer intermediate risk patient. Should we just lyse this patient, or should we do mechanical thrombectomy? Again, we'll come back to all of these. I don't want you guys to leave my talk thinking that I'm showing case examples, because many times case examples are beautiful to demonstrate, but may not be all the best evidence-based medicine. So we'll come back to evidence-based medicine for all of this. But anyway, so what do we do with this particular patient? So in this particular case, I mean, we knew that the patient was coming. And so the cath lab was available. She stabilized with the dobutamine and levofed. So we took her for a mechanical thrombectomy. So these are our baseline hemodynamics. Her heart rate was tachycardic 138, pulmonary systolic pressure is 55. Even on dobutamine, our cardiac index was pretty poor, 1.5, and our PaO2 on I think 6 liters of high flow nasal cannula was around 81. So we went in. This is a 24 French device from the right femoral vein. So we went in. The first order of business was to take care of the clot in the right atrium. So one aspiration, and we had what is called the corking of the catheter. So the thrombus was stuck at the mouth of the catheter. So you can see here we are injecting around it, and you can see a big thrombus cork around at the tip of it. So there are techniques. I'm sure you may have seen this at your institution. So we were able to take this out. We went to the right pulmonary artery, and again we had the same phenomena, corking of the catheter, nothing coming out. And we marched it back into the IVC. Again, you can see a clot here. We were able to take this out, and finally went into the right PA. Post-angiogram looks pretty good, not much residual thrombus. Again, here in different views, not much residual thrombus. This is the right upper PA, and again, you can see it's pretty good. We have taken care of most of the thrombus. We switched our attention to the left PA, and again, we had the same phenomenon, big clot stuck on the tip of it. So we marched it back in the IC and out, and finally went into the right left PA. Angiogram, clearly you can see not much residual thrombus left. This is what we got. You can see the big thrombus, and you can also see this. The background is my fellow. You can see the content on his face with the amount of thrombus we took out. It's not just all these pictures that makes a difference, but what's really important is the hemodynamics. So we do detailed hemodynamics pre and post procedure on 100% of our patients. Here you can see immediately our heart rate came down, our PA systolic pressure normalized, our cardiac index improved 30% on the table, and justly enough, within the next 36 hours, are happier. It's not as dilated as before. Looked like it's acting better. And the patient did pretty well. She's discharged a couple of days later. The fully normalized function. So just as a take home for this particular patient, so she came in as an intermediate high-risk PE patient. She was hemodynamically stable, low oxygen requirement, and but we had calculated a CPS score which suggested that she is at risk for every possible worse outcome. So we took her immediately, and as the score predicted, she deteriorated into a high-risk PE and went into shock. And after thrombectomy, she had significant improvement in her hemodynamics and did pretty well. So with that case in the background, so let's talk about therapeutic options for patients with pulmonary emboli. So options we have are anticoagulation or anticoagulation alone, or we can use on top of anticoagulation maybe systemic thrombolytic therapy. We have catheter-based therapies which come in two flavors, which is catheter-directed thrombolysis or mechanical thrombectomy. And finally, we have surgical thrombectomy. And let's look at each of these therapeutic options for the management of PE. If you look at the therapeutic options and potential trade-offs, the trade-off with anticoagulation is bleeding. And of course, anytime we are talking about anticoagulation, there is a risk of bleeding. But the other potential trade-off is what's on slide. So this is data from our own hospital. We looked at quality and rapidity of anticoagulation in patients with PE who were referred for mechanical thrombectomy. So we measured whether they were therapeutic on their anticoagulation at the time of mechanical thrombectomy, which was on an average around 6 to 12 hours after presentation. And you can see only 14% of patients were therapeutic at the time of mechanical thrombectomy. So the reason I want to emphasize this is many a times you have a patient present with PE, they're seen in the emergency room, They started an anticoagulation, and everybody feels like, oh, you're treating the patient. But just imagine this, only 1 in 10 patients are actually therapeutic. In other words, the 9 patients where you started anticoagulation are not even therapeutic. I mean, I don't think you can truly consider them as being treated for PE. The other issue with unfractionated heparin is a lot of patients can have supratherapeutic and subtherapeutic heparin values, and even 12, 24, 36 hours after diagnosis and starting treatment. So this is a big problem with unfractionated heparin. And because of this, if you look at the guidelines would say if anticoagulation is initiated, you should consider low molecular weight heparin or founder Paranox in such patients. I mean, we are slowly educating everybody to try to make that change. Part of the problem I feel is for acute MI, most hospitals have moved away from using low molecular weight heparin, and I think the same is true for unfractionated heparin. It has taken a lot of education to tell them that we will be okay even if the patient needs mechanical thrombectomy to do it on low molecular weight heparin. We really want those patients to be therapeutic and their anticoagulation if possible. So the other option for patients are using the systemic thrombolytic therapy. And of course, when we talk about lytic therapy, I mean, the first thing that everybody thinks of is if you have a high-risk patient, we lyse them. But interestingly enough, there are a number of trials, small trials, which have looked at using lytic therapy in intermediate risk patients. And these are very small trials. So it took a 16 randomized trial meta-analysis to have 2,000 patients. And in this meta-analysis, if you use lytic therapy, there was significant reduction in all-cause mortality. And the reason we don't use lytic therapy in intermediate risk PE, despite this data, is because of the fact that you have a price to pay with lytic therapy, which is increase in intracranial hemorrhage and increase in major bleeding. And because of this, in intermediate risk PE patients, lytic therapy is not the standard of care. That moves to the next question. So if you can somehow use lytic therapy, but at a lower dose and targeted to be given in the pulmonary arteries with the catheter-directed thrombolysis, can you have the benefit of lytics and at the same time minimize the risk of bleeding? Let's talk about catheter-based therapies. So with CDT, the amount of TPA delivered is around 20 milligrams. Interestingly enough, even though the bleeding risk is minimized, it's not zero. The major bleeding risk is around 6%. Intracranial hemorrhage is around 0.8%. So it reduces the bleeding from compared to systemic thrombolytic therapy, but does not completely eliminate it. The other major limitation of fibrinolytic therapy is what's shown on this slide. This is one of my days in the cath lab. So we did mechanical thrombectomy for a patient who presented with PE, and you can see the amount of clot we took out. Following this patient, I had a patient who came with a large anterior STEMI. So with this particular patient, we did thrombectomy and took out the clot. So I don't know how many of you can actually see this, but this is the amount of clot we had on this patient with the large anterior STEMI. So clearly, significant difference in the clot size and burden between PE and STEMI. We know a lot of data about systemic thrombolytic therapy in patients who present with STEMI. So let's compare STEMI with acute PE. In STEMI, the thrombus burden is small, as I showed you on the previous slide, whereas in acute PE, there's a lot of thrombus. In STEMI, the age of the thrombus is just a few hours, whereas in acute PE, it's days to weeks, as I showed some data, aging of thrombus here. And from what we know from STEMI literature, from a number of randomized trials, is efficacy of fibrinolytic therapy decreases with longer time from symptom onset. And because of this, guidelines would say it's best to use lytic therapy if it is within 60 minutes of symptom onset. And you can see here, efficacy like dramatically reduces. So if you guys all buy into this, I want to ask a question. If you're not willing to give lytic therapy for a patient who is a couple of hours late into his STEMI presentation, why are we open to giving lytic therapy for a patient who has PE where the clot has been in the legs for likely a couple of days to weeks? I mean, much older um, in terms of aging of that particular thrombus. So we'll come back to that particular aspects of it. And in terms of surgical thrombectomy, given the fact that these patients have a blown out RV, the worst thing that you can do is intubate them. The patients are going to crash. So, in my opinion, acute PE, there is no role for surgical thrombectomy. The ones who benefit from surgical embolectomy or thrombectomy are patients with CTEPH, which we won't talk much today. But for acute PE, there is much role for surgical thrombectomy. So let's talk about catheter-based thrombectomy versus anticoagulation alone. There are no randomized trial powered for clinical outcomes. There have been a number of single-arm studies, number of devices. I mean, there is literally an explosion of devices. They've all been single-arm. They've shown benefit at improving surrogate outcomes, significant benefit at 48-hour RVLV ratio, pulmonary pressures, uh, patient symptoms get better, quality of life better, but we really need randomized trial comparing anticoagulation alone. In the absence of randomized trial, we have a number of observational analysis. So this is our publication looking at National Readmission Database, where we had 14,000 high-risk PE, 42,000 intermediate risk PE, where we compared catheter-based therapies to anticoagulation alone. And we showed that catheter-based therapies reduces in-hospital death, all-cause readmission, and also VT-related readmission. Of course, observational design has a number of limitations. There are a number of ongoing trials. I want to highlight a couple of them. PE track is a trial, NHLBI funded, NYU. We are running this trial. 500 patients will be randomized to catheter-directed therapy. It could be either CDT or mechanical thrombectomy or systemic anticoagulation. Primary endpoint is peak VO2 at 3 months. The trial is doing pretty well. I think it's approaching over 300, 350 patients randomized. There is a bigger trial funded by NARI called Peerless 2, where it's looking at intermediate risk PE, 1,200 patients randomized to mechanical thrombectomy with FlowTriever versus anticoagulation alone. And the primary endpoint is a hierarchical win ratio of many different endpoints. Um, you know, um, in the interest of time, let me skip this. I think we'll have some time for discussion. I'll skip this discussion of mechanical thrombectomy versus catheter-directed thrombolytic therapy. Um, Maybe you're interested. We can talk about it during discussion and some of the from our own lab in this context. But I want to just switch to high-risk PE. I'm sure many of you are wondering, my particular patient was high risk PE. Why didn't we not lyse that patient? Because if you look at guidelines, this is ESC guidelines for high risk PE. The high risk PE, the guidelines would say systemic thrombolytic therapy is recommended for a high risk PE. It's a class 1 level of evidence B. So, for the fellows, I always would recommend if you see any guideline recommendation, make sure to dig into this evidence and figure out what is the study which led to these kind of recommendations. So, if you dig into this, the study that led to a class 1 indication is a trial by Jorge Sanchez from Mexico, published in 1995. So this randomized trial was 8 patients with massive PE. Again, I didn't misread this. This is an 8-patient randomized trial. Patients were randomized to unfractionated heparin or streptokinase. Primary endpoint was death. And if you were randomized to unfractionated heparin, everybody died. If you were randomized to streptokinase, nobody died. The trial was stopped early by DSMB. And this is the evidence for thrombolytic therapy for high-risk PE. The data is based off 8 patients, small trial. Interestingly enough, I was at this institution 6 months ago, and I gave a talk on PE, and it's interesting. So you can see the principal investigator of the trial. I mean, I must point out that the trial moved the needle forward, but I think we really need to ask the question: where does catheter-based mechanical thrombectomy fall when compared to systemic thrombolytic therapy because of all of the issues of aging of thrombus, which makes thrombolytic therapy not the best option for these patients. For iris PE again, our observational data would suggest that there is significant benefit of using catheter-based therapies versus anticoagulation alone, reduction in mortality, and also reduced risk of readmission. Let's skip this in the interest of time. And so these are my last two slides. So the evolution of PE care, I would say, is closely following that of myocardial infarction. So we talked about myocardial infarction and President Eisenhower, where the standard of care there was anticoagulation, analgesics, vasospasmodics, and a lot of prayers. Then we slowly moved into systemic thrombolytic therapy, primary PCI, and now primary PCI is the way to go. The same has happened in the stroke world, with just starting with anticoagulation to moving to systemic thrombolytic therapy and now to aspiration thrombectomy, stent retriever, etc. P, in my opinion, is moving slowly in the same direction, but in the majority of patients across the country, the treatment is still anticoagulation alone. Despite all these being said, PE continues to be a diagnosis problem. I want to leave you with this. This is Serena Williams after giving birth to her baby via C-section. Serena Williams was having trouble breathing and immediately assumed she was having another PE. She alerted a nurse to what she felt was happening and asked for a CT scan, blood thinner, but the nurse suggested that pain medication had perhaps left her confused. When the Doppler ultrasound revealed nothing, she underwent a CT scan, which showed several small blood clots in her lungs. She was immediately put on heparin drip, again emphasizing the need. This can happen in major academic centers that had the diagnosis of PE. So just to summarize, the current PE management, in my opinion, is similar to management at Eisenhower's MI with high morbidity and mortality. Guideline recommended risk scores are woefully inadequate with serious limitations. CPAS, we have over a dozen publications on this score. It predicts normotensive shock. It also predicts clinical outcomes and potentially can guide management. And for patient with intermediate risk PE, as I compared with STEMI and NSTEMI, AC anticoagulation alone is not adequate, and device-based therapies can potentially improve outcomes. There are a number of randomized trials. We should have the data within the next year or two, and hopefully this will provide the much needed evidence-based management for these patients. Thank you for your attention.
Thank you so much, Dr. Bangalore. That was amazing. You're really pushing the field forward with this, and we appreciate that you took time to show all the data to us. If you want to stop sharing your screen so we can just have the discussion, and for people that are in the audience, if you want to put your questions in the Q&A, we'll go through them. Asma is also with us. Asma, would you like to start with the first question as you're leading our program here at Monty?
So yes, I do have to say that excellent talk. I'm always a big fan of your talk, Sripal. And I have to say also that in the evolution of our program, not many of the people in the audience would know, but you have been kind of my mentor from a distance, and I often run cases by you, ask you about management questions, programmatic questions, and thank you for always being that person who's available to us, and in a way that our program growing is also in many ways I can say that it's you've tremendously helped in that as well, and thank you for doing that. So, and also I want to say that I cannot emphasize enough that now that I've been doing this for around 3 years, I cannot emphasize enough that how you have correctly pointed out in your paper, and we are now using that score routinely, that the how common normotensive shock is in patients with PE, and how absence of hypotension is absolutely misleading. And I have seen again and again and again patients who have cardiac indices of like less than 2, less than 1.5, and in a patient, if the same patient was having a heart attack, we would be trying to put multiple devices and support devices in these patients. But now with the identification of this normotensive shock, we've become more cognizant. But I do want to ask you something. Most of these I have seen recover once you do a successful thrombectomy and you decompress the ventricle successfully. How often have you had to use a mechanical circulatory device post thrombectomy?
So in our experience, first of all, I think you're doing a fantastic job. I mean, and congratulations for starting the program. And I think you're
Thank
one of
you.
the busiest programs in the city, at least from what I know.
Thank you. Thank
Um,
you. Yeah.
so I think there are, in terms of MCS, I think there are two aspects of it. One is during the acute phase, where around the time of thrombectomy, what we've shown from our data itself, I mean, of course, there is a selection bias depending on where you practice, and I
Mhm.
think this data may also be applicable to where you are. We have shown that in the acute phase, because we are catering to the sicker of the sick group, our requirement of crashing on to ECMO for that matter is close to around 3%. This is acute phase. In the post thrombectomy phase, I must say though the incidence requirement for MCS is very, very low. I still don't have a single patient where we did successful thrombectomy and hours or days later you needed any mechanical thrombectomy. I mean mechanical circulatory support to support their RV. And the patients who generally end up in trouble or have suboptimal results are typically patients where the PE is more chronic. They have had CTEPH, high pulmonary pressures, etc. Those are the ones I feel like will have potentially a suboptimal result. And again, I think that's why having per team and working closely, and so those are the patients, in my opinion, actually do very well if they're candidates for surgery for surgical embolectomy whenever they are stable enough.
Thank you very much for that
Thank
answer.
you. Thank
I
you.
think many hospitals or many people probably watching this are interested in starting a program. Can you describe briefly in your institution who calls the per team and where the patients goes after the procedure, and how many interventionalists are doing this?
Yeah, so our per team as critical care cardiologist, we have ICU person, we have interventional cardiology at the minimum. So these are the main one: pulmonary critical care cardiology, and ICU at the minimum. And then we involve others as needed. CV surgery, vascular surgery, IR if needed. But typically, if you have a patient, it goes to the on-call pulmonary critical care person who then activates the rest of the team. We all get on a call and then discuss. Previously, as Asma was also pointing out, previously it would lead to a good discussion. The pulmonary guys would say, "Ah, looks okay," and the cardiologist would say, "Oh, I don't think it's okay because the RV is struggling because we have a different perspective what we are looking at." And now it's all unified. We all look at the CPET score, so the decision-making process is very fast. Um, in terms of the number of interventionalists, I mean, at least at the Bellevue part of it, we only have two. It's me and one more person who's doing it, because I think it's very important for people to have enough cases. These are really sick patients, so right now we haven't opened it up for everybody, but it's the two of us who are on call for this.
Thank you very much. And how do there was a question from the audience, how do you decide between different devices? How many devices are available out there, and are they FDA approved or not? And how do you decide?
Yeah, so we have a couple of things. One is we are part of a number of clinical trials. So if a patient will fit into that trial, we'll use that device. I mean, it's more of trying to make sure that we get experience with new device to just to figure out, like, at the end of the day, which should be the best. So for us, if you have a patient who is not that sick but meets the criteria for mechanical thrombectomy, we'll try enrollment in clinical trials first, and whatever the device that trial is. But if the patient is really sick, then the decision will really depend on, do I want a 24 French catheter? Because, if the patient is crashing, many a times what we do, even before I pass a big bore catheter across the pulmonic valve, is to measure cardiac index. So if the cardiac index is extremely low, so for example, if it is below 1.5, the last thing you want to do is put a 24 French across the pulmonic valve and create an additional outflow tract obstruction, and those are the patients who will crash immediately. And many a times I have a strategy in place where we say we'll pause, with just the numbers, we'll optimize, increase fluids, dobutamine. And at that point, the decision is always to say, is this approachable by a 16-pinch penumbra device? If it is, we go with that. And if the thrombus, for example, the example I gave, the thrombus was really big, so I felt like I needed a 24 French device, we'll go with a 24 French device. But I think at the end of the day, just to be aware of RV hemodynamics is critically important.
Thank you so much for that clinical pearl. I think that's very important. And so I think we don't have any more questions, but thank you so much for your time.
So sorry.
Yeah, go ahead.
You did add a question. You did have a question earlier. I think, I think it's important to discuss this. Where do you? We want to understand. We're trying to make a protocol for our post care. Where do all these patients go post procedure in your institution, for example?
Oh, so great question. So right now, the pulmonary critical care is the one who receives the call, activates us, we take them to the lab, and they go back to the ICU. So it's the ICU guys who are taking care of these patients. There are, I must say though, it's a small proportion of patients who are transferred as an MI and incidentally found to not have an MI, but it's more of a PE. Those patients tend to stay in the CCU. But for the majority, it's the ICU guys who take care of it.
So, so many institutions, and including Athletics as well, we used to do that. They would go to a step down floor or an intermediate care unit. You just send them directly to the ICU or to the CCU. Yeah.
Yeah. So our workflow process is, and if it is intermediate risk PE or higher, they go to ICU as the first entry. And many a times, I mean, it's just a workflow issue that after thrombectomy, it's easier to just send them back because they already have a bed. They typically stay for less than a day and then get downgraded to the floors.
Got it. Thank you.
Thank you very much. Yeah, that's very important. So we're looking forward to seeing some more data on this and clinical outcomes from the trial. So we'll keep an eye for your publications. Thank you so much.
Thank you. Thanks for having me on.
Sripal, thank you very much.
Thanks, Asma. Bye-bye.
Bye. Thank you. Bye, Leandro. Thank you, everybody. Bye. Thank you.